The eye is also sensitive to changes in altitude. There's an increase in retinal blood flow at altitude which results in vascular engorgement, and if you looked into the eye you would see tortuous vessels and quite significant optic disc hyperemia. It's also worth remembering that the cornea is a relatively avascular tissue, and so it is particularly sensitive to hypoxia. That becomes important when you start to think about wearing contact lenses at high altitude. One of the things that can occur at altitude is high altitude retinopathy or retinal hemorrhages. There have been quite a lot of studies that have looked at the incidence of this, and of course you do get a lot of variance in these studies. One study showed that approximately 29% of people would develop a retinal hemorrhage on Mount Everest at altitudes between 5,300 and 8,200 meters. Another study looked at altitudes of around 4,240 meters and showed an incidence of approximately 4%. Certainly the incidence would increase with high altitude, but it also increases with exertion, and it appears to increase with the use of non-steroidal anti-inflammatory drugs such as ibuprofen, which of course are commonly used by people on treks of any sort for general aches and pains. There appears to be some correlation between the development of retinal hemorrhages and the risk of developing AMS, but that correlation is not totally clear. Often this is asymptomatic, and so there are probably many trekkers or climbers who develop a retinal hemorrhage, don't even know they've had it, go home and never find out about it. But it can result in impaired vision, and it can start to affect visual acuity. And if visual acuity starts to drop, then fundamentally you should descend. Generally speaking, an uncomplicated retinal hemorrhage as a result of high altitude retinopathy will resolve over 2 to 8 weeks post-descent. It's generally benign, but if it does occur, it should alert you to the small possibility that this patient may be at risk of developing AMS and HACE. And here you can see what this looks like. Here's a case of a patient who developed bilateral blurred vision at around 4,500 meters. You can see these hemorrhages here. This patient, in fact, didn't descend. They continued on to 7,100 meters, and they were now being examined 2 weeks post-descent. And in fact, no treatment was required, and their symptoms had resolved completely. So in the main, these are benign, but on some occasions, they can have an impact on your climbing, and they may have a more sinister connotation in terms of the potential for developing a more significant condition such as AMS or HACE. Contact lenses. Certainly, a lot of people use contact lenses at all sorts of altitudes, and they have been used very successfully. But it is important to remember that all contacts decrease the oxygen supply to the cornea. The cornea is a relatively avascular structure, and there's limited oxygen available as you go to high altitude. So, yes, you can use contact lenses, but there is an increased risk of bacterial keratitis. So the important thing is to use them very, very carefully. It's probably better to rest your eyes overnight and not wear extended wear contact lenses. So refresh them every day. Keep them extremely clean, exemplary approach to hygiene, bearing in mind that this can be quite difficult at high altitude, and also bear in mind that as you get higher and higher into colder zones, that your contact lens solutions can actually freeze. So it's important to think about storage. And if you're traveling with contact lenses, absolutely ensure that you have backup glasses. There's nothing worse than having 660 vision at that's corrected by contact lenses, and then finding that you're at 7,000 meters and your contacts are now dysfunctional because they've frozen, and you didn't bring your backup glasses. And bring lots of re-wetting drops, because your eyes will get dry in the relatively low humidity environment of high altitude. And at the end of the day, if you develop any symptoms, any irritation, any discomfort, you're far better off taking them out early rather than waiting for complications to occur. Some types of refractive surgery can be a problem at high altitude. Beck Withers was one of the climbers caught out in the famous storm in 1996 on Everest that resulted in so many deaths. He had had prior radial keratotomy, and as he ascended to higher and higher altitudes, his vision deteriorated further and further. And you can see this quote here where he states, "My vision had gotten so bad I couldn't see more than 3 feet." Radial keratotomy causes a hyperopic shift at altitude. And there's quite a bit of variation between individuals, but what it means fundamentally is that the shape of the cornea changes as you ascend to altitude, and as a consequence of that change in shape, you effectively lose your ability to focus. As that occurs, you then effectively become more and more vision impaired. This can be quite significant when climbing at altitude because, as in Beck-Withers' case, it can lead you to near virtual blindness. It's obviously important, if you've had any kind of refractive surgery, to make sure that you discuss that with your ophthalmologist before planning a trip to high altitude. And in this context, I'll define high altitude as probably being over 2,500 meters. Pregnancy. As you might expect, there's very little data about pregnancy at high altitude. You're not likely to be able to take a bunch of pregnant women, put them on the summit of Mount Everest and see what happens. So for obvious reasons, there are no real trials much beyond 3,000 meters. The data does suggest that it's safe to go to 3,000 meters, and remember that the baby is actually relatively well protected by the nature of the placental circulation from the effects of hypoxia.